Good evening. I'm Dr. Deepti Diwakar from the Department of Oral and Maxillofacial Surgery, Sri Balaji Dental College and Hospital. I'm here to present a lecture on orthognathic surgery. Brief outline of the craniofacial growth, diagnosis and treatment planning, mandibular orthognathic surgery, maxillary orthognathic surgery, facial asymmetry. So this is the diagrammatic representation of the craniofacial growth. This is an illustration of the neural crest migration pathways from the rhombomers 1 to 7 to pharyngeal arches 1 to 6 from the dorsal and lateral views. The image to the right side is a lateral view of a 31-day-old embryo showing somites along the back and development of the pharyngeal arches and limb buds. This is again a diagrammatic representation of the craniofacial growth. This is a pictorial representation of the craniofacial growth in 12 weeks. The right side of the diagram shows the incisive foramen, palatal graphia, soft palate, and the uvula formation. This figure shows the nasomaxillary intramembranous growth at various sites, resulting in an overall downward and forward transposition of the maxilla, which is related to the cranial base. There is an upward and downward backward direction of growth, and the overall downward and forward transposition of the mandible relative to the cranial base. Mandibular intramembranous and endochondral growth results in an overall downward and forward transposition of the mandible relative to the cranial base. An outline of the fetal mandible is superimposed on the adult mandible for size and shape comparison. So coming to the diagnosis and treatment planning, first one is the identification of the pathology and causes. Patients with severe discrepancies in the size and position of their jaws and their teeth often have difficulty in oral function. You have to check for this, check the TMJ, chewing and speaking abilities of the patient, dentist-patient communication expectations. Coming to the etiology, genetic pattern is an etiology, one of the reasons. Embryonic disturbance of growth, postnatal damage before or after growth has ceased, abnormal regulation of growth after birth, and there could be other etiology as well. Indications for orthognathic surgery: severe class 3, severe class 2, severe anterior open bite, markedly increased overbite, skeletal asymmetry. Classification based on symmetrical anomalies and asymmetrical anomalies. Data collection is very important. Clinical examination, and it is supplemented with static and dynamic recordings of the patient in 3 spatial dimensions. Most commonly used method: photography, study models, and cephalometric radiographs. Treatment planning: full detailed history, communication and psychological, extra and intraoral examination, facial aesthetics, radiography, study models, photographs, and team planning. So there are some recommended subcategories of appearance and aesthetics: macro aesthetics, mini aesthetics, and micro aesthetics. So the macro aesthetics involves the profile, the vertical proportions, lip fullness, chin projection, nasal projection, and the ear size. Mini aesthetics includes the incisor display, transverse smile, smile symmetry, crowding, smile arch. Micro aesthetics: gingival heights, triangular holes, emergence profile, spacing, tooth shape, and incisor angulations. Coming to the clinical examination, frontal face evaluation: forehead, eyes, orbits, and nose are evaluated for symmetry, size, and deformity. Symmetry of the canthi, eyelids, whether there's ptosis, entropion, or ectropion. Sclera, ocular imbalance, scleral show, midfacial deficiency. Intercanthal distance 32 plus or minus 3 mm and 35 plus or minus 3 mm. The interpupillary distance 65 plus or minus 3 mm. The intercanthal distance, alar base width, and palpebral fissure width should all be equal. Width of the nasal dorsum should be 1/2 of the intercanthal distance, and width of the nasal lobules should be 2/3 of the intercanthal distance. A vertical line through the medial canthus and perpendicular to the pupillary plane should fall on the alar basis plus or minus 2 mm. Cheek prominence 8 to 12 mm laterally and 10 to 20 mm inferior to the lateral canthus. Ears upper 1/3 just above the canthal level. Assessment of the lips: width of the lips equal to the interpupillary distance. If the asymmetry exists, cleft lip, facial nerve dysfunction, dental skeletal deformity. Lip incompetence is common in children. What looks like incompetent lips in childhood or early adolescence is merely a reflection of incomplete soft tissue growth. Females upper lip till 14 years, lower lip continues to grow up to the age of 16. Males growth of both upper and lower lip will continue till the late teens. The length of the upper lip should be one third of the length of the lower facial third, almost 22 plus or minus 2 mm in males and 20 plus or minus 2 mm in females. A normal upper tooth to lip relationship exposes 2.5 plus or minus 1.5 mm of incisal edge to lips. The facial midline, nasal midline, lip midline, dental midline all should be in line, and the face should be reasonably asymmetric, vertically as well as transversely. During smiling, the vermilion of the upper lip should fall at the cervicogingival margin with no more than 1 to 2 mm of exposed gingiva. Coming to the assessment of the profile, the forehead should slope anteriorly, accentuated as supraorbital rim, frontal bossing, supraorbital hypoplasia. The distance from the glabella to subnasal and from the subnasal to the soft tissue menton should be in a 1:1 ratio if the upper lip length is normal. Lateral orbital rims 8 to 12 mm behind the anterior projection of the globe. The globe is 0 to 2 mm anterior to the infraorbital rim. A line perpendicular to the Frankfurt horizontal plane and tangent to the globe should fall on the infraorbital soft tissues plus or minus 2 mm. The alar base has to be supported by skeletal nasal bone. Nasal bridge 5 to 8 mm anterior to the globe. Nasal tip subnasal to the subnasal alar base crease 2:1. If values of 1:1, maxillary deficiency is present. Nasolabial angle should be 90 to 110 degrees. The length of the upper lip should be one third the length of the lower facial height. Lower lip stomion to soft tissue menton should be twice the vertical dimension of the upper lip if the upper lip is normal in length. Mandibular area with the maxilla in normal AP position and the upper lip normal thickness, ideal chin projection is 3 plus or minus 3 mm. Posterior to a line throughout subnasal that is perpendicular to a clinical Frankfurt horizontal plane. The next is the labiomental fold. The labiomental sulcus should form a shallow S curve with the upper and lower portions similarly shaped. The prominence of the chin should be slightly less than the prominence of the lower lip. The neck to chin angle should be 110 degrees, throat length 50 mm. Skin laxity, cervical facial lipomatosis, high mandibular plane angle are conditions which obscure the definition. TMG examination, the range of movements, deviation from normal movements, any pain during movement, the joint sounds. Intraoral examination, periodontal health along with the history of smoking, excess alcohol consumption, bruxism, etc. Check the adequacy of attached gingiva, especially mandibular anterior region. Correct these problems if it's present. Tooth size discrepancy, occlusal relationship, whether it's class 1, 2, or 3. Dentition, overbite, plane of occlusion, curve of P. Transverse, posterior crossbite, maxillary deficiency. Horizontal, anatomical variation, crowding or spacing, overjet, missing or decayed retained primary teeth, impacted teeth. Soft tissues, general periodontal examination has to be done. Tongue size, position and activity, mentalis muscle activity, finger or thumb sucking. Photographs have to be taken to keep a record of the clinical findings. Different angulations have to be used in order to take the photographs. Frontal view, profile view, oblique view, occlusion or bite, cantic. Next is the radiography. Lateral cephalometric and panoramic radiographs are important tools for the assessment and as an adjunctive in diagnosis and treatment planning. In specific cases, it's better to have CBCT for definitive treatment planning and treatment. These are some of the examples of some of the radiographs. Next is model surgery. Model surgery is extremely important when it comes to orthognathic surgery. Pre-surgical orthodontics. The orthodontist is responsible for positioning the teeth to the most desirable position over the basal bone in preparation for surgery. Decompensation, then worsening the case as much as possible. Surgical planning. Avoid incisions on the face. First the bone should be touched, then the soft tissue. First correct the profile, then the occlusion. Occlusion is as important as the profile. Eliminate excessive growth as early as possible. Planning methods and rigid fixation. Coming to mandibular orthognathic surgery, you have BSSO, VSSO, inverted L or C osteotomy, genioplasty, and body osteotomies. Coming to the what plays a very major role is the anatomic considerations, vascular supply, nervous supply, and the muscles, the length and the direction of their function. Coming to bilateral sagittal split osteotomy, it's a predominant orthognathic surgery in the mandible. Intraoral approach, every possible move that includes the entire horizontal ramus of the mandible, advancement, setback, and rotation. The incision is started on the anterior portion of the vertical ramus. The upper limit is 6 mm. Rigid fixation is carried out. So this is a pictorial representation of the sagittal split osteotomy. So basically in this, parallel cuts are made through the cortex of the vertical ramus, and the medial cut being placed above the lingula, and the lateral cut being made about 1 centimeter below that. Complications of BSSO include stability, the amount of advancement, and the amount of relapse. Nerve damage, 19% have reported lingual nerve sensory changes, of whom 69% reported a resolution of symptoms within a year, and 88 reported altered daily activities. TMJ dysfunction is commonly noticed. Next is a bad split. This is an example of a patient in whom BSSO has been carried out. It includes a pre-surgical radiograph as well as a post-operative. Next is a vertical subcondylar osteotomy. There are different names which are used. It's an extraoral approach. It's a setback or a rotation technique. So intraoral VSO, the incision is made from midway up the anterior border of the ramus to the first molar, exposure of the entire ramus. The osteotomy cut should be made no more than 5 to 7 mm anterior to the posterior border at the anticipated level of the foramen. Forward and lateral movement of the proximal fragment by a small gauze pack while the opposite side is being completed. The mandibular dentation is brought into its new position. MMF is done. This is a pictorial representation of the technique. Technique is just as described above. Extraoral VSO. Approximately 4 centimeter incision is made 2 centimeter below the angle and the inferior border of the mandible. The inferior border of the mandible, you have to pay attention to the marginal mandibular nerve. The external approach has been advocated for large mandibular setbacks of greater than 10 mm, difficult asymmetries, or large vertical moves in patients with unusual facial structure. So, this is a pictorial representation. Complications, again, stability, TMJ dysfunction, and neural damage. There can be damage to the inferior alveolar nerve, which is a little rare. Inverted L and C osteotomy, both the condyle and coronoid in the same segment. The two procedures that seem to be the most popular are the inverted L and the C osteotomies. Extraoral approach, inverted C is done for horizontal mandibular deficiencies. Inverted L is correction of most kinds of mandibular horizontal discrepancies, including anterior open bite. Generally, advancements of the distal segment with either technique require bone grafting to ensure adequate bone union. The C osteotomy, an inferior horizontal cut is used. The submandibular incision is made 2 cm below the angle and inferior border of the mandible, approximately 6 cm in length. The medial periosteum may have to be elevated from some of the distal fragment to allow its advancement. Moist gauze is placed in the wound. Other side osteotomy is carried out. Mandibular teeth into the new occlusal position and secured with maxillomandibular fixation. This is again a pictorial representation of the technique. This is an example of a patient in whom this procedure was carried out with the preoperative and postoperative pictures. C osteotomy, horizontal cut that extended forward from the vertical cut below the inferior alveolar canal. This permitted a larger amount of bone contact when the mandible was advanced. They also realized that the problems caused by advancing the coronoid process and recommended either cutting the coronoid loose, which is coronoidotomy, or including it with a proximal segment, which is C osteotomy. That's a pictorial representation of C osteotomy. Complications again include stability, nervous injury, scar. Next is genioplasty. It includes an intraoral incision, horizontal osteotomy. The mental nerve is a structure that has to be paid attention to, and abscess of teeth. This is an example of a case in a patient in whom genioplasty has been performed. Next is Leaford 1 osteotomy. It's versatile. Advancement or setback can be carried out. Upper limit is 6 mm. Impaction or open bite vertical maxillary excess are procedures and are some of the reasons for which Leaford 1 osteotomy can be carried out. This is a pictorial representation of Leaford 1 osteotomy. A vestibular incision is played, a flap is elevated, and the maxilla is either setback or advanced, after which plating is done. Coming to facial asymmetry, it has a high correlation with attractiveness. Greater degrees of asymmetry are correlated with clinical depression, neurosis, inferiority complex, poor self-esteem, and general poor quality of life. Congenital anomalies acquired during in utero development and can be subdivided into malformations, deformities, and disruptions. Acquired anomalies are conditions arising from either trauma or pathology. Hemifacial microsomia, craniofacial malformation of the first and second branchial arches, presenting with asymmetric, unilateral or bilateral hypoplasia of the orbit, maxilla, mandible, ear, cranial nerves, and soft tissue. Proliferation and migration of embryonic neural crest cells or hemorrhage of the stapedial artery during fetal development. The true etiologic factors still remain unknown. Two important factors need to be considered in the treatment: facial growth potential and the restriction and its effect on surrounding structures. Degree of hypoplasia involving the glenoid fossa, mandibular condyle, and ramus unit. It is the most frequently encountered form of isolated facial asymmetry and the second most common congenital facial anomaly after cleft lip and palate. Incidence is between 1 is to 5,000 to 1 is to 5,600 live births. Males appear to be more frequently affected than the females. The right side is affected more than the left. It is usually unilateral and always asymmetrical if it exhibits bilaterally. Although hemifacial, it refers to one half of the face, the condition is bilateral. In 48% of the cases, the condition is part of a larger syndrome such as golden hour syndrome. Omen's classification: O is the orbit, M mandible, E is for ear, N for nerve, S is for soft tissue. Kruzansky and Kaban's classification: presence or absence of critical structures. HFM type 1 deformity: a generalized mild hypoplastic state, mild mandibular heterognathia and facial asymmetry. Type 2A: hypoplastic cone-shaped condylar head. Type 2B: moderate to severe hypoplasia. TMJ function is unsatisfactory. Type 3: complete absence of the mandibular ramus and condyle. This is a pictorial representation of type 1, 2A, 2B, 3. Treatment and early approach: a costochondral bone graft or distraction osteogenesis; a late approach, classical osteotomy with advancement of the mandible and lengthening of the ramus; a bimaxillary distraction osteogenesis; hemimandibular hyperplasia or elongation; diffuse enlargement of the condyle, the condylar neck, and the mandibular ramus and body. No etiological factor has been established. Condylar growth patterns can be evaluated by serial clinical comparisons, cephalometric tracings, and bone scanning. Treatment modalities have ranged from condylectomy to orthopedic maxillary management. Obvigesser and Maker classified the associated facial symmetries into three categories: hemimandibular dysplasia, which causes asymmetry in the vertical plane, which causes asymmetry in the transversal plane, and a combination of the above mentioned two entities. Diagnosis: OPG, models, photos, radioisotope bone scan, CT. Treatment: consider the evidence of neoplasia, consider evidence of continued growth, growth has not ceased, condylar shaving and condylectomy, growth has ceased, orthognathic surgery or surgical camouflage. Next is distraction osteogenesis. It generates bone and soft tissue, craniofacial reconstruction including orthognathic surgery, cleft palate and lip reconstruction, osteotomy of the bone site with minimal periosteal stripping. Latency period 3, 5 or 7 days depending on the surgical site. Distraction rate 1 mm per day. Distraction rhythm: continuous force application is best, yet device activation is more practical and allows for patient compliance. Consolidation until a cortical outline can be seen radiographically across the distraction gap, usually 6 weeks. Carried out for large skeletal movements, soft tissue and nerves, matrix ossification. Osteotomy in an area adjacent to an area of bone deficiency, applying slow tension forces, separates the bony edges, regenerates the chamber from which the new bone and soft tissues are formed, rate of distraction, rhythm of distraction, and regenerate the bone. So it has an osteotomy or surgical phase, surgery and distractor placement. Latency phase: inactivated early bone formation lasts 7 days. Distraction phase 1 mm per day, activation twice daily. Consolidation phase: appliance remains, regenerate bone is mineralized. Remodeling phase: appliance is removed, normal functional loads until complete maturation. Advantages is application of high forces, decreased neurosensory loss, less TMJ damage, and better long-term stability. Disadvantages: technique sensitivity to procedures, application and removal of appliance, increased cost and long-term period. Now, this is an example of a case where distraction osteogenesis has been performed. Surgically assisted rapid palatal expansion in adult maxilla with significant transverse deficiency is nearly impossible to correct with conventional orthodontic treatment. So in these cases, the expansion device is secured in place by the orthodontist. A surgical procedure is then completed by performing the bone cuts as described for a Leaford 1 osteotomy, with the exception that the most posterior attachment to the lateral nasal wall and perpendicular plate of the palatine bone are not divided. A midline cut is also completed to create separation between the central incisors, extending along the mid-palatal suture. After a latency period, the expansion device is activated 1 mm per day until the desired expansion takes place. During this time, a space develops between the central incisors along the mid-palatal suture and at the area of the osteotomy along the lateral maxillary wall. The regenerated bone gradually fills and matures in these areas. The appliance is then removed and active orthodontic treatment is begun to close the spaces between teeth, properly align the arch and maintain the expansion. In the case of mandibular deficiency, the initial surgical procedure involves performing an osteotomy and placement of the distraction appliance. After a latency period of 7 days, the distraction occurs with a rate and rhythm of 1 mm per day. Once this distraction is complete, the appliance is left in place for the consolidation phase, which is usually 2 or 3 times the amount of time required for the distraction phase. The appliance is then removed and active orthodontic treatment continues. Distraction appliances are also available for maxillary and mid-face advancement. In patients with a cleft lip and palate, substantial scarring often occurs from multiple previous surgical procedures. This scarring, combined with significant growth abnormalities, creates soft tissue limitations that may prevent single-stage single-stage correction with conventional orthognathic surgical techniques. Thank you.